Burger. I'm going to open it up to the panel and we'll spend a few minutes chatting with Dr. Scott Wellington and Dr. Ramadar. If you wouldn't mind getting on camera, that would be fantastic. And first, I'll just open it up if any of our participants have questions for our wonderful, informative panelists, please share. But I will open it up first because I have a question for Dr. Ramadar and for Dr. Scott Wellington. So I appreciate your insight in this. And my question is, this empowering. I think when you provide my chart portal for the adolescent to sign up, I think that's providing empowerment. And then talking to the adolescent about, hey, why don't you go and make your appointment? I'm curious, how have you navigated when you have pushback from the parent with these suggestions? I've had parents say, well, why does my child need to be on my chart? I'm curious to know what are some messaging that you do to, again, diffuse some of that tension, still acknowledging that you're the pediatrician or you're the doctor for both. So anyone wants to chime in first? Thank you.
I can go on forever about that,
go ahead,
but I don't know if Mariah wants to go first. It doesn't matter. I can go first. Can you guys hear me okay? So that is like the story of my life. And it's fine because it gives me more practice and it gives me more practice, kind of like having different parents. So a lot of times parents who do that still want their adolescent to become independent in other ways. And they don't see gaining access to their chart and making their own appointments is the same independence that they are striving for at home. And so usually what I step back and say, this really is not to form secret societies against you. And I hope that that is not what you feel. I want our communication to be open altogether. Howsoever, just like you want him or her to do the dishes, to make their bed, to do all those things independent of you, my job as their provider is to help them do things to make them independent as well. These are just a couple tools that we are putting in place to do that. And so really it is having a conversation because parents feel like we are kicking them out of this journey. And they're like, I've been on this journey for a long time. Why are you kicking me out? And I've done a good job up until now. And now you're saying that I'm not good enough. And so a lot of times they need validation, right? And so I switch that around a lot and be like, because they always can come up with things that they want them to do at home that they're not doing, right? Every parent has that. And I go, and so what type of things do you put in place to help them become independent? And then they name off that. And then I draw parallels. And a lot of times they back off because they just want to be heard and included into that. And so I find that that works best for me.
Yeah, I totally agree with that. It just, really focusing on the developing independence and that this isn't at an exclusion of the parents. Like, the teen having their My Chart account does not mean the parent cannot, I mean, depending on where you are, that these are, you know, and that you can still check in and have oversight, but then once you see, oh, you can make your own appointment and you can get there on your own, and you're still going to talk to me before the appointment and call me afterwards, like they can then start trusting, but we know that that's a process. And so we want to, and I think as much as you can say, like, that the parent is still a partner here, I'm going to involve you as much as I can and as much as your teen allows in the areas that they're allowed to have some say there. Like, I think that that can put people at ease.
We have a question. Can you speak to how Illinois remains a safe state for patients who identify as non-binary? Additionally, insurance coverage for providing gender-conforming medication. And this is really open to anyone who'd like to answer.
Yeah, I mean, the country is becoming more restrictive around access to care for gender affirming care. That is still preserved within Illinois. These regulations are generally, you know, at providing gender affirming care for minors. and and you know, Illinois, we are still able to provide gender affirming care to minors with parental consent. But access is still a huge struggle because as other states become more restrictive, people are having to leave where they live to seek care, move to places where they can feel safe and be safe. And, providers are not expanding at the rate that, people are seeking care. So though we, do have access here, it is still very limited and people wait a long time, unfortunately, to get that care.
I have a question for Dr. Shaw and Angela Berger. And this question is something that I grapple with, and I'm curious to get your insight on how to navigate those patients that are medically complex and it's time for them to transition. We have several reasons why we do that. One is it's challenging to expand our patients, to get new patients in. And so selecting a date that's mutually appropriate is a reason why we say, depending on the level of medical complexity, it might be 2021, it might be a little bit younger. But for those patients that are medically complex, how do we then find an adult clinician? I know you mentioned family medicine and med peds, but how do you find those doctors that feel comfortable taking care of these patients and accept Medicaid?
Yeah, so we tend to, it's a great question. I think that's a challenge that probably a lot of people on the call are facing right now. So Angela and I have the luxury and the benefit, thanks to Lurie Children's, of going door to door and building these relationships. Like we have the time, because most people don't, right? We do tend to, the med peds clinics at tertiary care institutions. Now, I think straight Medicaid is probably, for the trach vent population that's generally on straight Medicaid, not as much of a deal. But the MCOs, I think, provide a little challenge. Angela has in her office a table of institutions and which MCOs they take in like a grid. And so that exists in her office for us. Tertiary care academic institutions, we're blessed in the city of Chicago, luckily, to have Loyola, UIC, Rush, UWC for folks in the South in that area. And at Northwestern, we don't have a residency program, but we do have a few clinics that have med peds providers. And so most of these tertiary care institutions will take some of the MCOs, and between all of them, you can find somebody that'll take them. And most of them, if not all, will, in their med peds clinic, they will be comfortable finding access to those specialists. So I've got, somebody who needs neurosurgery, neurology, GI, ENT, pulmonary, and cardiology. What we tend to do is, Angela and I happen to know a lot of the people there because, again, we've had the luxury of going door to door. But they do take them, and wait lists are a problem. And I'll talk about that in 1 second. But we tend to make that referral, have them go see their primary care provider there. We ask that the pediatric specialists stay on while they're transferring their primary care until their primary care doctor over there can make all those referrals and then find all those specialists, and then one by one they drop off. So the process takes about 6 months to maybe even a year. The primary care tends to go first, sometimes longer, right? And sometimes we've had to write emails to our pediatric specialists to say, can you please stay on? I know you want to transition, but we're just doing the primary care now. Once their adult primary care doctor makes the referral to the adult neurosurgeon and they get in to see them, then can you sign off? Can you see them for 1 or 2 more visits? The answer has always been for our specialists at Lurie Children's, at least, yes. As long as there's a plan, I'm good. And so this is the importance of starting early, too, because there's also a wait list for the primary care doctors. And that plays a big challenge for us, finding some of these primary care doctors. The resident clinics tend to have less of a wait list. Right. And they tend to see, more of the Medicaid. But the non-resident clinics have a bigger wait list. So that's when we start to say, why don't we make this referral now? Have the primary care doctor, meaning yourself or somebody, stay on for a visit or two. And you, for all the primary care doctors out there, this is a process that I'm hoping you can meld into your own workflow, which is, make that referral earlier. Let the family sit on the wait list for a long time while you continue to see them, as long as you know there's a plan. And then once they get in to see them, ask your pediatric specialist, can you guys stay on? If you guys write to them, I bet they will. It's not just us that has really, I bet they will if you're worried about something going on.
Trickier is when we have a family who lives kind of far out. We work with families who live in parts of the state where it's rough, where we have really struggled. We have families who live in parts of the state where it's very, very challenging to find high quality primary care in medical systems. And that's where it's really tough, right? In the Chicagoland area, we actually can find primary care that take Medicaid for medically complicated patients. We've got a lot of connections in the Chicagoland area. We're pretty blessed. It gets a little tricky who takes what MCO, but we can figure it out, and we know a lot of people. But unfortunately, we have a lot of very vulnerable patients who live in parts of our state, and they come to Lurie Children's, and probably a lot of your practices from all over, because you guys are great, and Lurie Children's has a lot of great folks. But when they become adults, it becomes really difficult to find that medical care where they live, and that unfortunately is still a very hard struggle for them.
And it's reminding myself, I was talking about Chicagoland, but a lot of the attendees here are probably, throughout this is in Illinois, this is Illinois State. So a lot of the people on the calls are actually working in areas where their specialty care might not be hard to find. And I will say, OSF has a variety of things. We actually know MedPeds providers within the OSF system that can help us find it. And that's, I think, one of the larger systems throughout the state that we've used to help our providers. We have had families who they go to Lurie, so they're assuming that tertiary care in the city would be naturally transitioned over to Northwestern, which is not necessarily the case. Or they were willing to travel for tertiary care in the city. So again, that's where the primary care stays local. Tertiary care they might be willing to travel for, so that we can refer to some of the major but there, you're sort of responsible for finding some of the adult specialists there, and we happen to have lists of them, so it makes it easier for us. But again, OSF is a great system. We know MedPeds providers within the OSF system. We tend to use these liaisons. We do Google search. Angela and I do use Google to find providers, and we find providers sometimes.
Yeah. We have got really robust relationships with FQHCs as well. And I know we have our friends at Erie can handle an awful lot. I know maybe folks think that our partners at federally qualified health centers can't handle our medically complex patients, but they can. And our colleagues at Erie Family Health, most, if not all, I believe, are help me come up with the right words, are credentialed at Northwestern, Parag?
Oh, they have relationships with Northwestern. I think they can find Northwestern providers. They can find Northwestern specialists. But Erie, all our FQHCs work with a lot of different specialists all over the city. So, we've transitioned patients to everywhere. UIC, Rush, I would say Rush, UIC are probably two of our biggest. And then Loyola ranks up there in Northwestern, of course, too. But so it is a challenge. It's a very individualized process to answer. Yeah, to answer your question in a nutshell, it's a very individualized process that takes into consideration all these factors. But sometimes it's just reaching out, cold calling. It does end up being that.
I'll wrap this particular line of questioning up by saying I also will refer them, my patients that I'm transitioning that are medically complex or just in general, to contact their insurance. So the Medicaid, each individual MCO and Medicaid has their own link. So that's another option that I've had some.
Absolutely. It was on one of our slides and I forgot to make a highlight of that is insurance companies can find people. And again, as with everything, there's varying levels of which insurance companies are helpful and which are not, but they have care coordinators And we've met with one or two of them in the past few years just to see what kind of levels of service they would provide. So definitely, have your families, to cast a wide net, have them use their insurance company along with their own family and friends.
Any other questions from our participants this afternoon?
I actually had one, if that's okay.
Please.
Oh, is there somebody else that has one? Oh, there's somebody else that has one. I'll let them go.
Any tips for motivational interviewing for adolescents who do not show interest in taking responsibility for their care? Just for parents of adolescents in general.
I mean, there's like the whole point of motivation is like, what are your goals, and I think kind of like, what are the things that they want to do in their life, and then kind of I think what's helpful is kind of like playing that out into the future. So like, you know, when is your parent going to be doing this for you? Like, how could you do this? Like, what baby step could you do first to like, you like in picking up a medication, in scheduling an appointment, like, what are these little pieces that seem doable? Like doing it all at once can be overwhelming. And, especially for people with really engaged and involved parents, like that's wonderful. But then, how do you get out on your own? So I think figuring out those little things that like they think are doable, maybe highlighting like ways that they actually have taken control of like, and like really praising them for like things that they've done in the past that's been like, that they've done successfully on their own, and be like, you totally did that. Like, I think you could do this other piece too.
I'll piggyback off of that. So like the things that are brought up. So strengths, that's why we do the shades assessment, finding out what strengths that they have and using that as a tool. Also remembering their journey through brain development and adolescence. So sometimes they have to have goals that might be more short term. I know we always think about like life in the future, but adolescents don't always think about it like they think about like in the moment, in this time. And then when you sprinkle some risk factor on there, sometimes our future might not be the same future that they look at. I have learned from my adolescents that might be from higher risk environments. They look at their morbidity as like 25, right? And so think about when we're trying to get them to goals and do things that might be past what they see as their future, right? And so sometimes we really have to like stop, pause, see where they are, and then come up with goals that are more realistic to their life, their timeline, their thoughts of themselves. And so, which takes undoing in our brains, right? Because we're all like myelinated and we think of everything right now. We're thinking about what we're doing for, the rest of our day. And adolescents don't quite necessarily think like that. And so it's taking a step back and like remembering where they are developmentally. And we might be pushing them towards prom, right? Like, sometimes my goals are just very short. Between now and prom, which might be in 14 days, what can we get you to do? And that is a win, right? Because for every step along the way, that really is motivation.
Yeah, I would say we do the same. It's exactly that. It's keeping it simple, like one or two things, and the shorter the term, maybe the better. And, build off of wins, build off of strengths, see what they like to do, and just keep like one or two. We tell our division to like, just focus on one thing that you think that they need to know and then work on that.
Dr. Shaw, did you have a question?
Oh yeah, I wanted to ask Dr. Ramander about the confidentiality. How is it? Does the conversation change if it's an intellectually disabled or say you have? I'm thinking of like a 16 or 17-year-old who in the future is going to need guardianship. How does the access and those conversations? I'm just trying to envision like, but they're high functioning enough that they're able to have a conversation with you. are you still required or able, or is it best practice to maintain that sort of confidentiality when a 16-year-old who's severely delayed tells you about, like, for example, substance abuse or something like that? Does that change? I'm just trying to wrap my head around it.
In our state, we are not like, we are able to maintain confidentiality in these areas because teens can consent. However, we are not required to, okay? And I think so that makes it definitely can be this individualized and should be with patients with varying degrees of, of intellectual capacity and ability to understand consequences of things. And so that, I would want to say two things here. One, I would still encourage as much private time with patients that are verbal and can interact with you, that because I certainly have had patients where they're like in their 20s, I'm seeing them, meeting them for the first time, and they're like, "You're the first doctor to ever talk to me alone." And and so where, like they may not be consenting to all of their care, but they are definitely, like people have varying degrees of how much decision making they're making over their lives. And so not assuming that they're not. And so I would encourage that. But however, that we still may be including their parents in that decision. And I think as much as you can honor the assent of a patient, and I think, it it takes differing degrees of assent for like how invasive things are too. Like starting somebody on a birth control pill who may not fully understand that may be different than somebody who is saying, no, I don't want this IUD. And I can say that, So I think it really is individualized on like what you're talking about and how much this person, on your, like based on your clinical impression and your interaction with them and their family, you think that they can really understand. So yes, include the family. I think in many situations where you might, but I still might be like, thanks for sharing. Like if I'm talking to that patient alone, I will definitely like clue them in on things. I'm like, I think that this would be important for us to share with your family. Like, I'm so glad you're telling me this, and so.
Thanks.
I believe we have a lot of questions that or comments that are this was great and informative. But then there was a last question that mentioned that they have someone that they partner with that was only recently able to speak. She seemed unaware about teens and that they can give consent and what are their rights to confidentiality. And the question is, how would you suggest that that this person help with them learning that information about confidentiality, very similar to your presentation. And it could be, for both the adolescent medicine physicians.
Who is it? Can you clarify? I guess I can read it. Who's trying to learn about confidentiality? The patient, the parent, someone teaching the parent?
It looks like it's a PCP partner that this particular writer would like to provide information to help them better understand the rights of adolescents and with respect to confidentiality.
So I would say there's a lot of resources. I can try to find some and put it in the chat to email out. So when you talk about like comprehensive adolescent care and comprehensive the steps that I went through in the lecture, in it talks about like confidentiality. Again, the rules of our state might be different from some other states. And then it just talks about what questions, if you're to ask, would be considered confidential versus which ones aren't. So there's a lot of like AAP resources. So I can find some, put it in the chat, and then we can get it out to everyone, unless someone knows some off the top of your head. But there are a lot of resources available that you can kind of just share in like a continuing medical education type of way that outlines like confidentiality for adolescents and young adults.
And one way to like, if it feels weird to be like, so you're doing things wrong, let me teach you how to do it right. But like, be like, I went to this talk and I thought this was really, like really great. I don't know if like slides are being shared in PDF form or something, that like, you might be able, or, or the resource list or something, kind of like can say, hey, I thought this might be of interest to you too. Maybe a way to ease that in.
Okay, I think that we had some great discussion and some great presentations. And I thank everyone for coming today, Dr. Scott Wellington, Dr. Ramadar, and Dr. Shaw and Angela Berger for speaking today. Very much appreciate your time, and I appreciate all the thoughtful discussion and questions in the QA from our participants. And it's always a pleasure to work with Dr. Caskey. I think this was very informative for me, and it's information that I'm definitely going to use with my patients.
Thank you all so much, and you're getting such warm praise in the chat messages as well.
Yes, and thank you to Dr. Latimer and Dr. Caskey for fearlessly moderating and making sure all your questions got answered. Really appreciate all of you and your support of our Adolescent Health Initiative here at ICAP. We will be sending a follow-up email with a survey for you to fill out to receive CME, and we will include the recording as well as the slides from today. So I know you mentioned in that last question, if that could be helpful in kind of navigating that tricky conversation. You will all have that information. So thank you all so much for presenting and attending and sharing your Friday morning with us.
All right. Thank you all. Thanks all for having us.
Thank you, everyone. Have a good day.
Thank you.
Thank you.